Are you aware that fever shows up in up to 88% of adult ICU patients? But here's the catch, fever isn't always a sign of infection. Dive in as we unravel the complexity of diagnosing and managing fever in the ICU, focusing primarily on microbial causes that could be life-changing if treated early. Don't miss out, this could revolutionize your approach to fever in critical care. We will summarize the Society of Critical Care Medicine and the Infectious Diseases Society of America guidelines for evaluating new fever in adult patients in the ICU. Normal body temperature varies based on factors like age, gender, diurnal variation, and sampling site. CDC defines fever in hospital-acquired infections as a temperature greater than 38 degrees Celsius. For neutropenic patients, IDSA and National Comprehensive Cancer Network define fever as a single oral temperature above 38.3 degrees Celsius or sustained 38.0 degrees Celsius for at least 1 hour. SCCM and IDSA define fever in ICU patients as a single temperature measurement greater than or equal to 38.3 degrees Celsius. Absence of fever in infected patients can indicate worse outcomes. Recommendations in the guideline are generally applicable to ICU patients with suspected infection, regardless of fever. Central temperature monitoring methods like thermistors for pulmonary artery catheters, bladder catheters, or esophageal balloon thermistors are preferred for accurate temperature measurements critical to diagnosis and management. In the absence of these specialized devices, oral or rectal temperature measurements are suggested over less reliable methods. Methods considered less reliable include axillary or tympanic membrane temperatures, non-invasive temporal artery thermometers, or chemical dot thermometers. The recommendation for choosing oral or rectal temperatures in such cases is categorized as a weak recommendation and is based on very low-quality evidence. Routine use of antipyretic medications to reduce fever is not generally recommended in critically ill patients. For those who prioritize comfort by lowering body temperature, antipyretic medications are suggested over non-pharmacologic methods. The primary reason for reducing fever in the ICU is to decrease metabolic demand, especially in patients with limited physiologic reserves. A meta-analysis found that fever management reduced body temperature but had no impact on 28-day mortality, hospital mortality, or shock reversal. Take a chest X-ray of people who get a fever while they are in the intensive care unit, ICU. If a patient who has recently had surgery in the thorax, abdomen, or pelvis gets a fever, a CT scan should be done with the help of the medical service if the initial workup does not reveal a cause. If a seriously ill patient has a fever that won't go away and other tests have failed to diagnose the problem, an 18F fluorodeoxyglucose positron emission tomography (CT) scan might be worth doing if the risk of transport is acceptable. There wasn't enough information to say whether or not to use WBC scans on people with fevers that don't have a clear cause. An abdominal ultrasound or point-of-care ultrasound, POCUS, should not be used routinely on critically ill patients with fever who have no signs, symptoms, or recent history of stomach problems. If a patient has had recent surgery on their abdomen or if they have abdominal symptoms or a physical exam, POCUS, that isn't normal, as well as elevated transaminases or alkaline phosphatase, and/or bilirubin, a formal bedside diagnostic ultrasound of the abdomen should be done. If a patient has a fever and an abnormal chest X-ray, a thoracic bedside ultrasound is recommended, as long as there is enough expertise to more accurately spot pleural effusions and parenchymal or interstitial lung pathology. There isn't enough evidence to say that lung bedside ultrasound should be used on people with fever who don't have any problems with their chest X-rays. Blood cultures in critically ill patients with fever. For ICU patients with fever and no clear source, simultaneous collection of central venous catheter and peripherally drawn blood cultures is recommended. The rationale behind this is to avoid contamination and allow calculation of differential time to positivity, TTP. When central venous catheter cultures are required, it's advised to sample at least 2 lumens. Failure to sample from all lumens can lead to missed detection of bacteremia. For new fevers of unclear origin, rapid molecular tests on blood should only be used with concomitant blood cultures. These tests are faster but less comprehensive and should not replace traditional cultures. Sequential collection of at least 2 sets of blood cultures from different anatomical sites is advised. The sets should be collected one after the other, without pause, to improve yield and assist in interpretation of results. Culturing urine. For ICU patients with pyorrhea and suspected UTI, the urinary catheter should be replaced and cultures obtained from the new catheter. Positive cultures from asymptomatic bacteriuria could lead to overuse of antibiotics and misdiagnosis. Testing for viral pathogens. Suggested viral NAAT panels for new fever and suspected pneumonia. Viral testing considered at any stage of hospitalization if nosocomial infection is suspected. Multiple viruses can cause pneumonia, hence, panels covering a wide range are useful. Sometimes lower respiratory tract samples needed for certain viruses like SARS-CoV-2 and influenza. No clear evidence to recommend routine blood testing for viral pathogens in immunocompetent ICU patients. Herpesvirus and adenovirus generally not implicated in fever in such patients. PCT and CRP suggested for new fever with low to intermediate probability of bacterial infection. PCT and CRP not recommended for high probability of bacterial infection.